In part 2 of the 12-lead ECG review, we're going to discuss the basic principles of 12-lead ECG interpretation. So our objectives for this lecture: describe the basic principles of ECG interpretation, review the time intervals of ECG waveforms. We're going to review the 5+3 approach for 12-lead interpretation, explain aspects of a normal 12-lead ECG, and we're going to value the importance of timely response when dealing with an MI. So our basic principles: remember that an ECG is recording of the heart's electrical activity only. It cannot give us really any indication of the mechanical function. We have to do an assessment with our hands, our eyes, our ears, a perfusion assessment, but we can match up our patient with what we see on the monitor. We're looking at the electrical current moving toward the positive electrode causes positive deflection, so that would be a positive axis. And electrical current moving away from the positive electrode causes negative deflection, or negative axis, as it's traveling away. The stronger the current, the stronger the deflection. This is going to be important a little bit later when we're looking at different chamber sizes and things of that nature. So just really quickly, remember you've got your PR interval, which is going to be 0.12 to 0.20 seconds. Your QRS interval, which is going to be 0.08 to 0.12. We're really happy as long as it's 0.12 or less. Your ST segment, which is going to be important in the 12-lead. And your QT interval, which is usually 0.33 to 0.42 seconds. And there are some electrolyte abnormalities that could affect the QT interval as well. So these are all normal waveforms, normal intervals, normal heights, and all on this ECG right here. So our 12-lead interpretation with the 5+3 approach. So by the time that you've done your 12-lead, you should have already interpreted your underlying rhythm, and now we've already determined our rate, our rhythm, our P wave, the PR interval, and our QRS complex. Is it wide or narrow? So now we're looking at the J point to determine, do we have ST depression, ST elevation, or do we have a Q wave? So what are we looking for? Well, ST elevation, when you have an ST segment that is above baseline, that's going to be an indication of injury. ST segment depression or T wave inversion could be an indication of ischemia. But for all of these, we're looking for the J point, which is the point in which the S and the ST segment start. So in a normal 12-lead, one thing that we're going to look for is R wave progression. So in V1 through V6, we're going to be looking at R wave progression. The R wave should be small in lead V1, so it is small here. Throughout the precordial leads V1 through V6, the R wave continually gets larger. So we see that it continues to get larger. So this is a good R wave progression, to the point where the R wave is larger than the S wave in lead V4. So the R wave is not larger than the S wave in V2 or V1, but if you notice in V4, is starting to get larger than the S wave. The S wave then becomes quite small in V6. So again, we notice that the S wave is pretty much gotten smaller. So the S wave then becomes quite small in lead V6. This is called a normal R wave progression. Now you can have some abnormalities when the R wave remains small in V3 to V4, that is smaller than the S wave. Then the term poor R wave progression is used. But our waveforms are normal throughout the strip. In our monitoring strip here, looks like we've got a normal sinus rhythm. We've got narrow complexes all the way around. We don't have any prime waves. We don't have any deep S waves. We don't have any slurred R waves or slurred S waves in leads 1, AVL, and V6. So this looks like a normal 12 lead. But, very important, a normal 12 lead does not rule out MI. And remember what you've learned in class. Any patient that's experiencing chest pain is going to be considered cardiac chest pain unless proven otherwise. And we're not going to really prove it otherwise in the field. In the early stages of acute MI, the ECG may be normal or near normal. Less than half the patients with acute MI have clear diagnostic changes on their first tracing. That's why we get that initial tracing and we do additional tracings. About 10% of patients with a proved acute MI, which includes a clinical history and those enzymatic markers such as your troponins or your CKMB, failed to develop ST segment elevation or depression. But don't forget, time is muscle. So time is muscle. So we need to understand what we're looking for when we get this 12 lead. We always want to get a 12 lead initially. We want to get it sent to the hospital as quick as we can. Remember, all patients that are experiencing any type of chest pain are going to get a 12 lead. And this ends part 2.